Great. So just out of interest, I'm going to talk about group consultations now, and we're going to cover the history, understanding that patients being involved in the design of this model of care are important, hear the benefits, see what we're doing in the UK and the plan to spread, and that this is a two-way conversation, so both patients asking about research and researchers sharing and developing research. We've been doing this now for 10 years, and in rheumatology we see maybe 12 to 20 patients in one room together, not one-to-one. So the whole idea is you have to set up the ground rules. It lasts for at least an hour, usually closer to 2 hours. There is more time to answer questions, more time to ask questions, and obviously a lot of people have the same questions. So the key thing is it's creating time when we are resource limited, when up until this week, when some new money was announced for the NHS has been expected to save money when we've got more and more treatments available and we're struggling to deliver, more care to more people. There is peer support because you are, with others who are affected by the same issues, but we need to understand it's a different space, so because you're not alone in a room with a doctor or nurse, that you are operating under shared confidentiality. The equivalent, I would suggest to you, is if in this room we decided that you would ask questions today, but we wouldn't share it, we wouldn't stream it on the web, and we wouldn't discuss it inappropriate with your neighbour or your family after you've left the room, that would be the equivalent. So it's gaining from each other's experience without breaking the confidentiality that still exists in a shared sense. Does that make sense? Because some people struggle with it until they see it. That gives us as clinicians and you as patients better continuity and better relationships. That gives us the same or better results, depending on the area we do it in, and the same or better satisfaction, okay? It doesn't seem to be worse, ever. And there's lots of different names for this. So my next slide is to explain a little bit about some of the different names. And I'm only going to highlight that our model both promotes access and is good for chronic care, and we call it group clinics. The other model that's often used in primary care, and we've just done some training in the Northeast, so there are 50 practices who are starting to put this into practice now. It's usually called a shared medical appointment, okay? So it may be coming to a surgery near you soon. And then the other thing to highlight is there's really good evidence of group antenatal care, particularly from the American experience in Yale, but they're also doing some research in London on that. But the whole point is that it's a long list of different names, but the key thing is lots of patients together, clinicians dealing with them at the same time, and powerful effects. The only thing I wanted to highlight about this little history that was prepared by a colleague of mine is that we're recognised as being the first in the UK, but there are several other groups doing it, especially in primary care, and it's probably closer to 200 general practices doing it now. Has anybody heard of the New England Journal of Medicine? Yeah, a few nods here. Yes, well done. Has anybody heard of the Lancet? Because Professor Loughlin wasn't blowing his own trumpet, but obviously a lot of his research was published in the Lancet a few years back. And these high-impact medical journals are read by more people. When other scientists then write about the research from them, that leads to them being cited, and that means that they have a bigger influence. But the New England Journal is right up there for general medical journals, as is the British Medical Journal. So those of us who've been doing the group models for a while, we were very excited last year when both of these major medical journals did editorials. The first one was written by, you've heard of Darzi, Lord Darzi, the polyclinics and all that? He used to be a government minister when we had a Labour government. That was a little while ago. Seems a long time ago now, doesn't it? And Kamalini Ramdas, who's a professor at the London Business School. Essentially, they're trying to help spread innovation. And with this particular model, the group clinics, they said there were 4 key drivers needed. You needed local evidence of value, ways to pilot and adapt, incentives, and good education. That's both on the patient and the clinician side. And then later in the year, there was an editorial in the BMJ that said this, so that it was a promising response to an escalating demand. It takes so long to train clinicians that this is one of the few ways that we can improve care within the foreseeable future. So unlike when you have to develop a new medication, it's going to take 5 or 10 years, this is something that I can train somebody today and they can do it tomorrow. So it really can be transformative in that way. Here's the patient perspective, because one of the responses to the British Medical Journal editorial was a blog written by a patient, a doctor who was writing as a patient, and this recounts the experience of our initial patient representative, who frankly didn't fancy the idea of these groups when we first talked about them, but she came along to see one last year, and when she did come, she found it very positive. And people who are trying and coming for the first time, if they have an open mind, they can enjoy it. What we're not trying to suggest is that you will always be seen in a group. We're just saying, when you try it, you might well enjoy it, and there's benefits to it. This brings together the evidence. We've just done a review article for the Future Healthcare Journal, and this points out that across the life course, pregnancy, young children across early life, I'm going to focus mainly on the adult age group, where there's really strong evidence. You can improve pain, you can help diabetes, so you can control the measures we have of long-term sugar control, you can reduce blood pressure, high blood pressure, you can get people better at managing their own disease, and you can improve their knowledge. In chronic airflow limitation, you can reduce care use, improve exercise tolerance, so you can do more, so you're not as restricted. Again, improving knowledge and improving quality of life. For the older age group, because we had a big show of hands when we asked how many people had arthritis, but the trouble is older people have lots of other things too. And so it's really important to have evidence that you can manage multiple conditions and people who have several different conditions. And there's a key publication from the United States which showed in people with multiple conditions, you can do all these things. You can reduce admissions. So that's good, keep you out of hospital. You can improve satisfaction, improve quality of life, improve self-efficacy. It costs less because of the efficiency of the model. You can reduce the number of drugs people take, and the trouble is, as we get older, sometimes you end up taking too many drugs, okay? That's not good for anybody, because they all start interacting and you get more problems, and it costs everybody, and then you can also reduce incontinence. So some quite powerful evidence. In our clinics, this year, our average group size was 22, except we did this in ANIC yesterday, and we had 26 patients. And it didn't even last 2 hours. It was 1 hour and 3/4. So that's about 4 minutes per patient on average. We do it in the round. So if we were doing it in this room, we'd get rid of all the tables and we'd sit all the chairs in a circle. And then we'd have a flip chart at the front. And we would say at the beginning, here are the ground rules. What questions have people got? And because we had the nurse doing the clinic yesterday, I answered a few questions quickly. Then I went into a separate room to do micro-consults, and people came in 1 or 2 at a time to have a look at their joints. We could score the joints and make a little plan in what we call the micro-consult, while the nurse stayed in the room and delivered education. This is great because often our patients don't get enough education. This delivers fantastic education at the same time as you get in your clinical care, and that's why the outcomes are better. We have an educational poster and obviously a talk from the team. We've got really explicit targets because it turns out when you've got chronic disease, if you aim for a target and treat until you get that target, you do better, okay? And it's a shared target. It's agreed together, whatever condition you've got. We agree in rheumatoid arthritis to get low disease activity or preferably remission, and we celebrate remission, deliberately so. We used to have people waiting to have steroid injections because when you've got inflammation, the steroid injection is good as a short-term measure to settle the inflammation quickly, whereas the tablets act much longer, and the two together work much better. But we set it up now so the injections are given during the clinic, and then people are all finished by the end. And we set the rules are that we can laugh and we can joke because we'll have more fun, and laughter's the best medicine, okay? We have refreshments, and thanks to our outpatient sisters for doing that. And we might have the nurse one day, the pharmacist the next month, the podiatrist. So it's a rotating input. And over the course of 6 months, we'd have the members of the team all come. So the bell is to remind me that this started as a joke, and I was standing up in a group clinic one day in ANIC Infirmary, and I said, this is an American model of care. If we did this in the States, if somebody went into remission, there would probably be whoops. Okay? There would be fist pumps, and they might even ring a bell. And one of the patients piped up, and they said, oh, we've got an old bell that they used to use to ring last orders in a local pub that's shut now. Shall we bring in the bell? And we agreed, so this is co-design, we agreed we were going to start ringing the bell for remission. Okay? And what started as a joke turned out to be a really powerful tool in communicating and in inspiring and in moving forwards, because now we're in a separate room. The people in the main room still hear the bell when it's ringing for the remission, and when we did the qualitative study, which asked people what they think and what's the important themes, this was one of the main things that came out. The bell was ringing today. Goodness me, I look forward to when the bell is ringing for me, for when I'm in remission. So people know it's possible, and they understand that other people are achieving it, and that we can achieve more together. So it's become quite a powerful driver. So what about the questions patients ask? Well, to start with, it's always led by the patients. So whatever questions they want are the ones that get answered. And of course, when you read in the Daily Mail, why is it always the Daily Mail?
Tuesday.
Yeah, okay. So whatever study has been published in the papers, the classic one, of course, we were just at a meeting in Amsterdam, and there was this study where they'd put in a box into patients with rheumatoid arthritis to stimulate their vagus nerve. And people were saying, can I have a box for my arthritis? And I said, well, not quite, because this is a small study. They haven't controlled it properly. That's not given us definite answers yet. And actually, they still haven't done the study right. So the question is, we can address answers. We can give people hope because we can share the latest research. There are queries from family and friends. There are new treatments coming through. And when we go to a meeting, we can share what's happening. But then also, there is a space for people who the current treatments are not perfect, whether because of infection risk or because they've tried them all. And then there's an opportunity to say, well, maybe this study would be right for you, and we can put you into a research study, okay? So, for example, LIPIPRA is a study for people who have the blood tests that tell us they're almost certainly going to develop arthritis. But before they start developing it, and we've had patients who've gone into that study, and then if they do still develop rheumatoid arthritis, they come back to the group, and it works very quickly and smoothly because it's integrated care. Does that make sense? Okay. So then we sometimes bring questions to the group when we're planning research. So for example, some of the genetic work we're doing in Newcastle is looking at potential biomarkers called microRNAs for both aging and for osteoarthritis. And we consulted on a project grant we were putting into the Biomedical Research Centre, and the patient said, this is great and fantastic that a pharmacist is taking part in it as well, because that might lead to quicker treatments. And so we had really good engagement that way. We obviously are doing some research about the group consultations themselves, and that's important to ask people about that. And when you're discussing and responding to published papers and discussing in the session. So the outcomes are good. In terms of the low disease activity score of remission, about 40%, and the average size of groups is increasing. I'm very, very keen to include the video at the end, which I think is one of the most powerful things. So I'm just going to whisk through the last slides. Very positive feedback on satisfaction across all domains. And the patients, once they've tried it, they really do love it. So we were shortlisted for the Lancet Research Award, so this is being recognised as an excellent model of care. We didn't win the overall award, but the team were pleased to get that far because it certainly raises awareness of the model. And we've persuaded the president of the Royal College of Physicians, Dr. Bod Goddard, he's called, is going to do us a little video on the group clinics, and that helps to promote it further. The key things are you're benefiting for the patients, continuity, peer connection, confidence. For the clinicians, efficiency, it's more fun. It's actually more fun for everybody. It's a challenge to do it to start with, and you can see people more often. And for all of us together, we have longer together, improved outcomes, and closer relationships. We've got the chief medical officers on board to spread this across the NHS in the next 5 years. And finally, I'm going to leave my patients with the last word.
I wasn't too sure at first, but I attended one, gave it a go, and I've been absolutely hooked ever since.
So it isn't just a rheumatoid clinic, it's anything to do with pain as well. And you sit and you're taught, and that's why I like coming to this group. So you learn something every time you come.
I find the group clinics very beneficial. A lot of things I've found because various people bring up a subject and you think, oh, I've got that, but I haven't thought of mentioning it. You know, I just thought that's me. but as it is, it's part of the illness. And it's great when you are in a group clinic like that, because somebody will bring up what you think is a minor thing.
With the group sessions, you get properly examined, get all the treatment you need the same day, but you also get the benefit of a lot more information about the drugs, the treatments and your condition.
The main thing is first name. Now that is a big difference. When the doctor sort of takes the time to look up and say, oh, hello, Colin, instead of Mr. George, Mr. Brown, and away you go. And you get this friendship going, and it's a pleasure to come.
I think it's good because you're still getting to see your specialist and getting your one-to-one, as well as also going into your group and getting little bits of snippets of information which helps you. So internally I'm thinking, well, I'm coping with this because I know what I'm doing. And there's a lot of things that maybe it's on a one-to-one I wouldn't think to ask him.
And then you also get all the benefit of the questions being answered that people have asked, and the inspiration of other people in the group who are so amazing how they cope with really being, a lot of them, much worse than I am.
To be serious, suicidal. 3 attempts. Loneliness, aches, pains, can't do this. All this, just took it away. And that's what it did to me. When you sit and think what you've just been through, and you kick yourself up the backside. Because you're sharing what you're thinking about. And of course everybody then starts laughing, and then you start talking to each other. And then the next thing you know, you talk to somebody on that side of the room, and then everybody starts joining in, putting their experiences in.
Everybody is so positive and so determined to make the most of the life that they've got with arthritis, and I would encourage anybody to come and be inspired by other people.
Just gets me every time. I'd just like to point out that this is done with a big group, both in our clinical team in terms of national spread and our international advisory group, and just remind you what we covered. I'm very aware that it's time for more refreshments, isn't it? Is there anybody who really wants to ask a question now, or shall we break up and you grab individuals within the break that we're going to have? How many people would be willing to try a group consultation? Okay, great. Most of you, great. That's nice to know.